All right, so you know how sometimes you get a little cut, like a paper cut, and you're bleeding for a minute and then suddenly it just stops?
Yeah, it's one of those things you don't really think about, right?
Right, exactly. But it's super important, obviously.
Yeah.
So today, we're going deep into this whole process, this hemostasis thing, basically how your body just knows how to stop bleeding.
And, you always want to learn things fast, right?
Yeah, definitely. Efficiently.
Efficiently, exactly. So we're going to get right to it.
Okay, so it seems simple on the surface, but
Oh, yeah, it's way more complicated than you think. It's like a whole bunch of steps happening all at once with different cells and all kinds of proteins involved.
okay, so we've got some pretty in-depth medical stuff to go through here. Audio lectures, notes.
Yeah, we're going to break it all down so we can understand exactly how our bodies plug those leaks and, what to do when things aren't working quite right.
Exactly, and this is all for you listening.
Mm.
We'll make sure you get the key stuff without getting lost in all the details. No jargon overload.
Yeah, no, we're not going to do that.
So you can walk away really understanding this fundamental, thing that your body does.
When you think about it, hemostasis, it's like everywhere in medicine, surgery, trauma, even understanding how diseases work.
Oh, yeah, absolutely.
So if we get this down, it's going to make understanding all that other stuff so much easier.
All right, so let's start with the basics. Normally, blood just flows through our vessels, no problem, right?
Yeah.
No clotting.
No clotting.
So what's going on there that keeps everything smooth?
Well, the key here is the endothelium. That's the inner lining of our blood vessels, and it's really smooth. And when it's healthy, it releases these signaling molecules.
Oh, okay.
And two really important ones are prostacyclin and nitric oxide.
Prostacyclin and nitric oxide.
Yeah.
What do those do?
So those guys basically tell platelets, hey, chill out, everything's fine.
Oh, so like the peacekeepers.
Yeah, exactly. Like,
Yeah.
keep calm and carry on. So prostacyclin, that helps to stabilize these things called 2B3A receptors on platelets.
2B3A.
Yeah, 2B3A. They're kind of like docking sites that platelets use to stick to each other. So by keeping them inactive, prostacyclin prevents any unwanted clumping.
Okay.
And both prostacyclin and nitric oxide also inhibit the release of these little packages inside platelets called granules.
Oh, granules. Okay. What are those?
Yeah, they're basically little storage units that contain all these substances that make platelets stick together, like ADP and calcium.
Oh, I see.
So keeping those locked up and the 2B3A receptors inactive, the endothelium makes sure that platelets just keep flowing smoothly without causing any trouble.
Okay, so that's the normal situation.
Yeah.
Everything's peaceful, the blood's flowing. What about when something goes wrong? Like you get a cut and the blood vessel is damaged.
Right. So then that smooth lining, the endothelium, it gets disrupted.
Yeah.
And then things get a little bit more exciting.
Okay, so what happens?
So when the endothelium's damaged, what's underneath gets exposed to the subendothelial surface and collagen.
Subendothelial surface and collagen.
Yeah, and that triggers the first stage of hemostasis, what we call primary hemostasis.
The primary hemostasis.
The platelet phase.
Okay, so the platelets come in.
The platelets are the first responders.
So how do they know to come to the rescue?
Well, when those platelets encounter that exposed collagen and subendothelial surface, it's like a signal flare goes up.
Okay.
They're like, oh, something's wrong here. We need to fix it. And then they become activated.
All right.
They start sticking to the injured area. They clump together and they change shape, becoming more spiked and sticky.
Spiked and sticky. So they're like little, burrs?
Yeah, basically they're trying to plug that hole.
Okay, so they're forming a plug. Is that enough to stop the bleeding?
Well, it's a good start, but it's still pretty fragile at this point.
Oh, okay.
To really seal the deal, those activated platelets release a bunch of chemical messengers.
Oh, okay.
It's like they're calling for backup.
Okay, so what are they sending out?
Yeah, they release things like thromboxane A2, ADP, serotonin, and PAF, which stands for platelet activating factor.
Wow, they got a lot of tools in their arsenal.
Yeah, they're pretty well equipped. And these chemicals, they act on nearby platelets that are still just cruising along in the bloodstream.
Oh, okay.
And it makes them activate and join the party at the site of injury. It's like a positive feedback loop. The more platelets that arrive, the more signals get released, and the more platelets get called in.
So it's like a chain reaction.
Exactly, like a snowball effect.
Okay, so inside the platelets, what's happening that makes them release those signals and become all sticky?
Well, on a cellular level, when a platelet gets activated, the concentration of calcium ions inside the platelet goes way up.
Okay.
And that surge of calcium, it triggers the release of those granules that we talked about earlier.
Right, the little storage units.
Yeah, the ones that are full of all the stuff that makes platelets stick together. And it also releases more of those chemical messengers, so it really amplifies the whole response.
Okay, so we got this initial plug. It's kind of loose, but it's getting amplified.
Right.
But you said it needs to be strengthened.
Right, and that's where secondary hemostasis comes in.
Secondary hemostasis.
Also known as the coagulation cascade.
Oh, okay.
And this is where we get a much stronger, more stable clot.
So this is like the reinforcement team.
Exactly.
Okay.
And it involves a whole bunch of proteins called clotting factors.
Clotting factors.
Yeah, it's like a whole cascade of events.
Mhm.
See, the body's got this layered approach to clotting. It's got the quick response with the platelets, and then this more robust, long-lasting system with the coagulation cascade.
Oh, so it's like a double-layered protection.
Exactly. It's a really important process, so it needs to be done right.
Right, right. So what's the main goal of this cascade then? What's it trying to achieve?
The ultimate goal is to turn fibrinogen, which is a soluble protein just floating around in your blood,
Okay.
into fibrin, which is an insoluble thread-like protein. So these fibrin threads, they form a mesh that traps platelets and red blood cells, basically weaving a net over that initial platelet plug.
Oh, so it's like reinforcing the plug.
Exactly. It makes it much more stable and stops the bleeding for good.
Makes sense. And who's the key player in this transformation of fibrinogen into fibrin?
That would be thrombin.
Thrombin, okay.
It's like the master weaver.
Oh, okay.
It acts as an enzyme, cutting up fibrinogen molecules to create those sticky fibrin threads, and then they self-assemble into the fibrin mesh.
So thrombin is essential. But how does the body actually make thrombin in the first place? You mentioned a cascade, so it sounds like a series of events.
Yeah, exactly. There are two main pathways that lead to the activation of thrombin: the extrinsic pathway and the intrinsic pathway.
Extrinsic and intrinsic. Do those get triggered by different things?
Yeah, they do. The extrinsic pathway, that's usually triggered by trauma, damage to tissues outside of the blood vessels.
Okay.
It starts when blood comes into contact with tissue factor, which is also called factor 3.
Factor 3. Okay.
Yeah. It's released by damaged cells in the tissues around the injury. And this pathway involves clotting factors 7 and X.
Okay.
And it's pretty quick, happens within seconds usually.
Wow, that's fast.
Yeah, it's got to be. Now, the intrinsic pathway, that one's triggered by damage to the inside of the blood vessel itself.
Oh, okay.
Like when blood touches certain surfaces that are normally hidden away.
Right.
And it involves clotting factors that are already in the blood, like factors 12, 11, 9, X, and 8.
Okay, so it's using what's already there.
Exactly. And this pathway's a bit slower, more complicated than the extrinsic pathway. Takes a few minutes to get going.
So you've got the fast response and the slower, more complex one. But do they both work independently, or do they connect at some point?
Oh, they definitely connect. Both pathways eventually lead to what we call the common pathway.
The common pathway.
Yeah. And this is where they both activate factor X.
Okay.
And once factor X is activated, it sets off the final steps. Prothrombin gets converted into thrombin.
Right, which is the master weaver.
Exactly. And then thrombin converts fibrinogen into fibrin.
To make that mesh.
Yeah, to make that strong mesh. And then we have factor third, which comes in at the end and kind of cross-links and stabilizes the fibrin clot, making it even stronger.
Oh, wow. So it's like a multi-step process with checks and balances.
It is. It's quite remarkable how the body has evolved this intricate system to make sure bleeding stops effectively.
Absolutely. So we plugged the hole with platelets,
Mhm.
reinforced it with the fibrin mesh, job done right, everything goes back to normal.
Not quite. If that clot just stayed there forever, it could actually block blood flow even after the vessel has healed.
Oh, right.
So there's another process called fibrinolysis.
Fibrinolysis.
Yeah, and this basically breaks down the clot gradually.
Okay, so it's like the cleanup crew.
Exactly.
Okay.
And it involves converting plasminogen, which is inactive, into its active form, plasmin.
Plasmin.
Yeah.
So what does plasmin do?
Plasmin is like a little Pac-Man. It goes around and breaks down the fibrin mesh into smaller pieces that the body can clear away.
Oh, I see. So the clot just kind of dissolves.
Exactly. And there's also another thing that happens during fibrinolysis. Bradykinin gets released.
Bradykinin.
Yeah, and that causes blood vessels to widen. It's a vasodilator.
Oh, okay.
And this helps to counteract the effects of serotonin and prostaglandins, which were released by the platelets earlier, and cause blood vessels to narrow.
Oh, right, right.
So it helps the vessel to relax, and blood flow can return to normal.
So it's like a reset button.
Yeah, exactly. It's a really elegant way for the body to regulate itself.
That's amazing. So the body stops the bleeding, and then it cleans up after itself.
Mm.
But what happens when things aren't working right?
Right, that's when we need some help from medications.
Okay, so what kind of medications are we talking about here?
Well, there are two main categories: antiplatelet drugs and anticoagulants.
Antiplatelet drugs and anticoagulants.
Yeah.
Okay.
And It's interesting. A lot of these drugs, they target very specific steps in this whole hemostasis process.
Oh, that's interesting.
It shows how much we understand about how it all works, but it also means there can be unintended consequences, because it's all so interconnected.
Right, right. Because if you mess with one part, it could affect another part.
Exactly. So we have to be really careful when we're using these medications.
Okay, so let's start with antiplatelet drugs.
Okay.
So those are focused on the platelets, right?
Right. They basically stop platelets from getting too excited and forming clots.
Okay,
There are a bunch of different types that work in different ways.
let's start with aspirin.
Okay, aspirin, that's a good one. Everybody knows aspirin.
Yeah, I take it for headaches sometimes.
Right. It's a pain reliever, but it also has antiplatelet effects.
Oh, okay. So how does it work for that?
So aspirin inhibits the synthesis of thromboxane A2.
Thromboxane A2.
Yeah, remember that chemical messenger released by activated platelet?
Right, right. Calls in the other platelets.
Exactly. So aspirin blocks an enzyme called KOX1, which is needed to make thromboxane A2.
Yeah.
And it does this irreversibly,
Irreversibly meaning.
meaning once aspirin blocks KOX1, the enzyme is basically out of commission.
Oh, wow.
And platelets, they can't make new KOX1, so the effect of aspirin lasts for the entire lifespan of the platelet.
Oh, so it's like a long-lasting effect.
Yeah, exactly. That's why even a small dose of aspirin every day can really reduce the risk of clots.
Okay, so because it's irreversible, it's really effective.
Yeah, it is. And that's one of the things that makes aspirin different from other antiplatelet drugs.
Okay, so what do doctors use aspirin for then, besides pain relief?
Well, it's often used to prevent TIAs, which are like mini strokes,
TIAs.
transient ischemic attacks.
Okay.
And it also helps prevent heart attacks and lowers the risk of cardiovascular problems in general, both for people who have had a heart attack or stroke before and those who haven't but are at higher risk.
Okay, so it's kind of like a preventative measure.
Yeah, exactly.
What kind of doses are we talking about here?
Usually it's around 75 to 81 milligrams per day,
Okay.
but sometimes doctors might prescribe up to 325 milligrams per day.
Okay, so it depends on the situation.
Right. It depends on the patient and what they're trying to prevent. And it's important to note that higher doses can increase the risk of side effects.
Right, so what are some of the downsides of taking aspirin?
Well, the main risk is bleeding,
Oh, okay.
especially in the GI tract, the stomach and intestines.
Okay.
And less commonly, there's a slightly higher risk of hemorrhagic stroke.
Hemorrhagic stroke.
That's a stroke caused by bleeding in the brain.
Okay, and the risk of bleeding is higher if you take higher doses, right?
Yeah, exactly. And if you have a history of ulcers, that also increases the risk.
Okay, so that's something to be aware of. And is there anything else that can interfere with how aspirin works?
Yeah, actually, there's an important interaction with ibuprofen.
Ibuprofen.
Yeah.
So
Yeah.
like Advil and Motrin?
Yeah, those are common brand names for ibuprofen.
Okay, so what's the interaction?
Well, both aspirin and ibuprofen, they block KOX1.
Right, that's how they work.
But ibuprofen, it does it reversibly.
Reversibly, meaning it's not permanent.
Yeah, exactly. So if you take ibuprofen too close to when you take aspirin, it can actually block aspirin from binding to KOX1 and having its long-lasting effect.
Oh, so it's like they're competing for the same spot.
Yeah, exactly. So if you need to take both medications, it's best to take aspirin at least an hour before ibuprofen, or at least 8 hours after.
Okay, so that's something to keep in mind.
Definitely.
Okay, what's another type of antiplatelet drug?
All right, so another group targets the GP-IBT2A receptors on platelets. Remember those docking sites?
Oh, yeah. Those are the ones that let the platelets stick together.
Exactly. So these drugs like ifsiximab, eptifibatide, and tirofiban, they block those receptors.
Okay, so even if the platelets try to stick together, they can't.
Yeah, that's the idea. They basically prevent fibrinogen and von Willebrand factor from binding to the receptors, so the platelets can't form those bridges between each other.
Oh, I see. So it's like cutting off the connection.
Exactly. And it's a really effective way to inhibit platelet aggregation.
Okay, so how are these drugs given and when are they used?
They're given intravenously, usually in a hospital setting.
Okay.
And they're often used along with heparin and aspirin, especially during procedures like angioplasty.
Angioplasty?
Yeah, that's when they open up blocked arteries in the heart.
Oh,
And ifsiximab is also specifically approved for some patients with unstable angina when angioplasty is planned.
okay.
So it's a pretty specialized use.
And since they're given intravenously, are there any risks?
Well, yeah, the biggest risk is bleeding, especially when they're used with other blood thinners.
Right, so it's something that has to be monitored carefully.
Definitely. It's serious stuff.
Okay, what about the third category of antiplatelet drugs?
All right, so this category includes clopidogrel, ticlopidine, prasugrel, and ticagrelor.
Okay, so those are all kind of similar.
Yeah, they all work by blocking ADP receptors on platelets.
ADP receptors.
Yeah, remember, ADP is one of those chemical signals that activated platelets release to call for backup.
Oh, right, right.
So these drugs, they prevent ADP from binding to its receptors.
Okay, so they're stopping the signal before it even gets to the receptor.
Exactly. And that reduces the activation of those GP-IROBOA receptors that we talked about earlier.
So it's like a domino effect. They're blocking one step, which then stops the next step.
Precisely. And it's important to note that some of these drugs, like ticagrelor, they bind to the ADP receptor reversibly.
Meaning the effect wears off.
Yeah, exactly. Once you stop taking the drug, the effect goes away pretty quickly. But others, like clopidogrel, they bind irreversibly, similar to aspirin.
Oh, okay. So the duration of the effect depends on the drug.
Right, and it also takes different amounts of time for these drugs to reach their full effect. Clopidogrel, for example, that can take several days.
Wow, that's a while.
Yeah.
So what are these ADP receptor inhibitors used for?
Mainly for preventing things like heart attacks, strokes, and peripheral artery disease, especially in people who have already had one of those events.
Okay.
They're also really important for preventing clots in patients with acute coronary syndromes.
Acute coronary syndrome.
Yeah, that's like when you have a sudden reduction in blood flow to the heart.
Oh, okay.
And they're used during angioplasty as well. Ticlopidine, that's a bit more specialized. It's used to prevent TIAs and strokes in people who have had a thrombotic stroke before.
Thrombotic stroke.
That's a stroke caused by a blood clot.
Okay, so it's really targeted for that specific situation. Are there any risks or side effects with these drugs?
Yeah, ticlopidine, it can cause some serious blood problems, so it's not used as much anymore.
Okay.
Clopidogrel is generally safer, but there's still a risk of thrombocytopenic purpura, or PTP.
TTP.
It's a rare but serious blood disorder. And prasugrel and ticagrelor, they have a black box warning about bleeding risk.
Black box warning, that's the most serious kind of warning, right?
Yeah, exactly. It means there's a significant risk of a serious or even life-threatening side effect.
Okay, so that's definitely something to be aware of. And ticagrelor, you said it doesn't work as well with high doses of aspirin.
Yeah, that's right. If you take more than 100 milligrams of aspirin per day, it can actually reduce the effectiveness of ticagrelor.
Oh, okay, so that's another interaction to watch out for.
Yeah, and there's another important one with clopidogrel.
Okay.
Certain drugs, like omeprazole, which is used for heartburn, they can interfere with how clopidogrel is activated in the liver.
Okay.
So if you're taking those drugs together, clopidogrel might not work as well.
Wow. So there's a lot to think about when it comes to these medications.
There is. It's a complex area of medicine.
Okay, so we've covered antiplatelet drugs.
Right.
What about anticoagulants? Those are the ones that target the coagulation cascade.
Exactly. They basically interfere with the clotting process, either by directly inhibiting clotting factors or by reducing their production.
Okay, so let's start with warfarin.
Okay, warfarin. That's probably the most well-known anticoagulant.
Yeah, I've heard of that one.
So warfarin is a vitamin K antagonist.
Vitamin K antagonist.
Yeah, it basically interferes with vitamin K.
Okay.
And vitamin K is really important for making certain clotting factors in the liver.
Oh, okay.
Factors 2, 7, I, and X.
Okay.
So by messing with vitamin K, warfarin prevents these clotting factors from being made properly.
I see. So it's like sabotaging the production line.
Exactly. It's a clever way to reduce the amount of active clotting factors in the blood.
And how do doctors know if warfarin is working properly?
They use a blood test called the INR,
INR.
the International Normalized Ratio.
Okay.
And because warfarin has a narrow therapeutic window.
Narrow therapeutic window.
Yeah, it means the dose that's effective is pretty close to the dose that can cause problems.
Oh.
So they have to check the INR regularly to make sure the patient is getting the right amount.
So it's a delicate balance.
It is. For most conditions, the target INR is between 2 and 3. But for some things, like mechanical heart valves, it needs to be higher.
Okay, so how is warfarin given and what's it used for?
It's a pill taken by mouth, and it's absorbed really well. It's mainly used to prevent and treat venous thromboembolism.
Venous thromboembolism.
Yeah, that includes DVT, deep vein thrombosis,
Okay.
and PE, pulmonary embolism.
Pulmonary embolism.
It's also used to prevent strokes in people with atrial fibrillation and those with prosthetic heart valves.
So it's used for a lot of different things.
Yeah, it's a very versatile drug.
You mentioned that it affects the production of clotting factors in the liver. Does that mean it takes a while to work?
Yeah, it does. It usually takes about 3 to 4 days for warfarin to reach its full effect.
Oh, wow. That's a lot.
Yeah, because it's not directly blocking the clotting factors that are already in the blood, it's preventing new ones from being made.
Right, right. So what are the risks with warfarin?
Well, the main risk is bleeding, just like with any drug that affects clotting.
Okay.
And it can be tricky to manage because there are a lot of things that can interfere with how warfarin works, like other medications and even some foods.
Oh, wow. So you really have to be careful.
Yeah. If there's minor bleeding, they might just stop the drug for a bit or give vitamin K to reverse its effects.
Oh.
But if it's serious bleeding, they might need to give a higher dose of vitamin K intravenously or even give fresh frozen plasma, which contains all the clotting factors.
Wow, so it's pretty serious stuff.
Yeah, and warfarin can also cause birth defects, so it's not safe for pregnant women.
Oh, okay.
And it has a ton of drug interactions because it's metabolized by certain enzymes in the liver.
Okay.
So drugs that affect those enzymes can either increase or decrease the levels of warfarin in the blood,
Yeah.
which can make it either more or less effective.
So it's a drug that requires a lot of monitoring and careful management.
Definitely. It's not something you just take without thinking about it.
Okay, so what are some other types of anticoagulants?
Another important group is the indirect thrombin inhibitors.
Indirect thrombin inhibitors.
Yeah.
What does indirect mean in this context?
So these drugs, they don't directly block thrombin, which is that enzyme that makes fibrin.
Right, the master weaver.
Exactly. Instead, they work by binding to a protein called antithrombin III.
Antithrombin the third.
Yeah, and this protein naturally inhibits clotting, but heparin makes it way more powerful.
Oh, okay. So it's like giving antithrombin the third a boost.
Exactly. So it's an indirect way of blocking thrombin.
Okay, I see. And what are some examples of indirect thrombin inhibitors?
The main one is heparin.
Heparin.
Yeah, and there are also low molecular weight heparins, or LMWHs.
LMWHs.
Yeah, those are like modified versions of heparin.
Okay.
Enoxaparin and dalteparin are examples of those.
Okay,
Yeah.
so how is heparin given and when is it used?
Heparin has to be injected either intravenously or subcutaneously.
Subcutaneous.
Yeah, under the skin.
Okay.
It's not absorbed well if you take it by mouth,
Uh-huh.
and it's often used for treating DVT and PE because it works really fast.
Oh, okay. So it's like
Yeah.
a rapid response drug.
Exactly. It's also used to prevent clots after surgery and during dialysis.
Dialysis.
Yeah, that's a treatment for kidney failure.
Oh, okay.
And to make sure heparin is working right, they monitor the APTT,
APT.
the activated partial thromboplastin time.
Okay.
It's another blood test.
So a lot of monitoring is needed for these drugs.
Yeah, you got to make sure the dose is right.
What are the risks with heparin?
Well, the main one is bleeding, just like with warfarin.
Okay.
And there's also a risk of heparin-induced thrombocytopenia, or HIT.
HIT.
Yeah, it's a rare condition where heparin actually causes a decrease in platelets, which is kind of paradoxical.
Oh, wow. That's strange.
It is. But luckily, there's an antidote for heparin if there's a serious bleeding problem.
Oh, okay. What is it?
It's called protamine sulfate.
Protamine sulfate.
Yeah, it basically neutralizes heparin.
Okay, so they always have a backup plan.
Yeah, you got to be prepared.
Okay, what's next?
All right, so next we have the direct thrombin inhibitors.
Direct thrombin inhibitors.
Yeah.
So those directly block thrombin.
Yeah, unlike heparin, they don't need a middleman.
Okay, so they're more direct.
Exactly. And one example of a direct thrombin inhibitor is dabigatran.
Dabigatran.
It blocks thrombin that's free in the blood and also thrombin that's already bound to a clot.
Okay, so it's kind of like a two-pronged attack.
Yeah, you could say that. And it's a pill, so that's convenient.
Oh, okay. So it's easier to take than heparin.
Yeah, definitely.
What are the advantages and disadvantages of dabigatran compared to warfarin or heparin?
Well, a big advantage is that you don't need to monitor the INR like you do with warfarin.
Oh, okay, that's good.
Yeah, and it also doesn't interact with as many drugs as warfarin because it's not metabolized by the same enzymes in the liver.
Okay, so less monitoring and fewer drug interaction.
Exactly. But there's a catch.
Oh.
There's no readily available antidote that can reverse its effects quickly if there's a serious bleeding problem.
Oh, so that's a concern.
Yeah, it is. Although an antidote is now available, it wasn't at the time of many of the studies that were done on dabigatran.
Oh, I see. So that's something to keep in mind.
Definitely.
Yeah.
And it also has to be used carefully in people with kidney problems or elderly patients because they're at higher risk of bleeding.
Okay.
And it can't be used in patients with mechanical heart valves.
Okay, so it's not for everyone.
Right.
Okay, what's the last group of anticoagulants?
All right. So the last group is the direct factor inhibitors.
Direct factors inhibitors.
Yeah.